Dear colleagues, dear students, we continue the psychiatry lectures from the University of Pécs, Hungary. Today's topic is schizophrenia. Schizophrenia is a clinical syndrome of variable, profoundly disruptive psychopathology, which involves cognition, perception, emotion, and other aspects of behavior. The expression of these manifestations varies across patients and over time, so there are quite different symptomatological presentations, as we shall see. There can be a patient with auditory hallucinations, another patient with serious catatonic stupor, the third patient with negative symptoms, social withdrawal, anhedonia, emotional withdrawal. So there are quite great differences in the symptomatology. Probably comprises a group of disorders with heterogeneous etiologies. So there are many researchers, many clinicians who believe that schizophrenia is not one illness, but schizophrenia is a group, as Bloiner called it, and with very different etiologies, very different diseases are called with one name as schizophrenia. For example, there is a mental retardation which is called the DiGeorge syndrome, the velocardiofacial syndrome, where the prevalence of schizophrenia is very high. It's about 55 to 30%. And these cases are quite different from another patient with schizophrenia who is a university student with very good intellectual capacities. So we can say that there are many so-called subgroups of schizophrenia. Schizophrenia is always severe and usually long-lasting. Typically it starts around the age of 55, but there are some cases which start during the adolescence. There are rare cases which start during childhood. We know about childhood onset schizophrenia. There are some cases where the illness starts in the adolescent period. Typically, it's the age of 55, and there are some cases which starts later in the 30s or in the beginning of the 40s. The lifetime prevalence of schizophrenia is nearly 1%, from 0.4 to 1.4% is the range which studies proved. Incidence and prevalence rates are roughly equal worldwide, but there are some urban areas where there are higher rates, and some industrialized nations there are higher rates. And schizophrenia can be found in all societies and geographical areas, which was shown in a classic WHO study from 1975, the International Pilot Study of Schizophrenia, which resulted these data. The gender and the age nearly equally prevalent in men and women, but there are differences in the onset and the course of illness. In the case of males, the illness starts earlier. The peak ages of onset are between 15 to 25 years, while women display a bimodal age distribution. 55 to 35 years is one peak, and there is another peak after the age of 40. The outcome of female patients is better compared to males. Males are more likely to be impaired by negative symptoms, which means worse prognosis, and women are more likely to be better in social functioning. So these are. Etiology of schizophrenia. There is not a single cause. There is a very strong genetic background of schizophrenia. As we had seen, nearly the prevalence of schizophrenia is 1%. But if somebody has a first-degree relative with schizophrenia, then the risk for developing schizophrenia is 10 to 15%. In the case of twins, in the case of monozygotic twins, the concordance rate is about 50%, while in the case of dizygotic twins, the concordance rate is only 10 to 15%, which represent a great genetic contribution to the etiology of the illness. Impaired neurodevelopmental can be mentioned, as in the case of ADHD, in autism, in mental retardation, or in Tourette syndrome. schizophrenia is also a neurodevelopmental illness, which means that brain development is aberrant. There are deficits in the brain development. Typically, two neurodevelopmental deficits can be identified. The first is the early neurodevelopmental model, or the early neurodevelopmental deficit, which means that during the neuronal migration, which appears during the embryo phase of the patient, the migration of the pyramid cells is disturbed, and this is responsible for later brain pathology. And the other is the late neurodevelopmental model, which means that the adolescent aged synaptic pruning or synaptic elimination, a normal process that there is a decrease of the synapses number during the adolescent period. So this synaptic pruning, this synaptic elimination is disordered in schizophrenia, and this is the second so-called neurodevelopmental hit we can identify. There are biochemical factors, neurotransmitters as dopamine, glutamate, serotonin, and GABA can be identified. And some environmental factors are also responsible for the etiology of schizophrenia. One is cannabis use. We know that cannabis increases the risk for schizophrenia, especially in a subgroup of individuals who show a specific polymorphism of an enzyme, the catecholomethyltransferase enzyme, the COMT enzyme, which is an enzyme which works in the dopamine metabolism. And if there is in a certain base pair, there is a valine-valine polymorphism compared to the valine-methionine or to the methionine-methionine base pair patients. In the case of valine patients, if they use cannabis, the risk for schizophrenia is 2 to 4 times higher if they use cannabis after the 20s. If they use cannabis during adolescence, then the risk for schizophrenia, if they are valine patients, then is 6 to 8% more. So there is an increased risk of schizophrenia in the case of cannabis use and in the case of a certain polymorphisms of the COMT enzyme. Migration is an important risk factor. We know more and more about these data. And stressful life events also. If we have a look at the etiology genetics, I have already mentioned viruses are important. We know that influenza A2 and toxoplasma, which is not a virus, are responsible. They increase the risk for schizophrenia. Malnutrition, starving during pregnancy of the mother increases the risk for schizophrenia in the embryo 20 years later. Birth injury, obstetric lesions, hypoxia, and asphyxia during the delivery can mean a risk factor for schizophrenia, and stress too. These all leads to impaired neurodevelopment, as I have mentioned, which leads to the disruption of the neuronal connectivity, neuronal circuits, communication between different brain regions are disturbed, and this leads to the symptoms of the illness. The most known and most researched neurotransmitter background of schizophrenia is the dopamine hypothesis. There are 4 regions, 4 pathways where dopamine play an essential role in the brain, and what we know that the hypodopaminergic status in the mesocortical pathways are responsible for the negative symptoms and the cognitive symptoms, while hyperactivity, hyperdopaminergic status in the striatum, in the mesolimbic system, in the limbic system, is responsible for the positive symptoms for schizophrenia, hallucinations, and delusions. If you have a look at the symptomatology, the name schizophrenia comes from this Swiss psychiatrist, Bleuler, who introduced the term schizophrenia for this patient. Previously, Kraepelin called these patients as dementia praecox patients, early dementia. And Bloiler said that not dementia is the most important main characteristic of this illness, but the kind of splitting, a kind of schisis in the case of this patient. And what Bloiler meant by this was that he said that there are two words of the patient. There is a psychotic word and there is a non-psychotic word of the patient. In the psychotic word, the patient believes that he is a special agent from the Mars who is responsible for mankind. And besides, he knows that he is a retired lawyer and he needs to take antipsychotics and he is in a mental hospital. And these two words, the psychotic word and the non-psychotic word, coexist. And they do not disturb each other. The patient can tolerate this kind of discrepancy between the two words. And this is Bloiler meant by splitting. This is what Bloiler emphasized, that this schisis, this splitting of the mind, which is typical for schizophrenia. He called this double bookkeeping as a mechanism. And also, Bloiler summarized four symptoms, the Bloilerian 4As, which you have to know. The fundamental symptoms as association problems, primary incoherence, illogical fragmented thought processes, affects, flat affect, blunted affect, autism, which means a withdrawal to the patient, a private autistic fantasy world, and ambivalence, which means a simultaneous contradictory thinking and feelings. For example, the patient has a strong symbiotic connection towards the mother and believes that the mother is poisoning him. So this is the typical example for a schizophrenic ambivalence. And also there are accessory symptoms which can be shared with other disorders as hallucinations, delusions, and catatonia. Another German psychiatrist, Kurt Schneider, spoke about the first-rank symptoms. These are schizophrenia-specific symptoms, characteristic for schizophrenia. For example, voices conversing with each other, voices commenting the patient's action, thought echo, the patient hears his thoughts spoken aloud, delusions of being controlled or being influenced, thought withdrawal, the patients believe that thoughts had been taken out of his mind, thoughts insertions, the patient feels that some thoughts were put into his mind by somebody else, thought broadcasting. And these are the so-called schizophrenia-specific first-rank symptoms. And Schneider talked about second-rank symptoms, which can appear in other illnesses too. Today, the symptom clusters of schizophrenia are these four: positive, negative, cognitive, and affective symptoms. Let's see the positive symptoms. Delusions, usually they are bizarre, which means that something which can never happen, nonsense, that I have visited the Mars today, or I visit the Pacific Ocean every afternoon and I meet with sharks there. So these are impossible delusions, and these are typical for schizophrenia. Hallucinations, which are typically auditory, acoustic hallucinations, these are the most common. There is a command type of hallucinations when a voice commanding the person to perform some action, to do something. The voices instruct the patient to kill himself or to kill somebody. So suicidal and homicidal intentions can be said by the voices. Disorganized thinking and behavior, looseness of association, incoherence, disintegration of behavior can be seen. And movement disorders, catatonic symptoms, catatonic excitement, or catatonic stupor, as we have learned in the first semester, can represent the positive symptomatology. Negative symptoms of affective flattening, a kind of emptiness, which can be seen in the patient, lack of emotions. These are typical facial immobility and unresponsiveness, reduced body language, typical alogia, which means an inability to form and articulate thoughts, poverty of speech, anhedonia, lack of pleasure, evolution, and social withdrawal. These are the negative symptoms that we had seen. Hypofrontality of the brain is responsible for these symptoms. There are some cognitive symptoms in schizophrenia. These are not so serious as in the case of mental retardation or dementia, but these exist, and these means a problem for the patients. A lower level of functioning is the consequence of the cognitive symptoms, as poor concentration, impaired memory or disorientation, attention problems, executive functions, which means the problem-solving intelligence can be disturbed, and we know that behind the executive dysfunctionality, the dysfunction of the dorsolateral prefrontal cortex can be found, working memory, speed processing, these are all can be seen as cognitive symptoms in schizophrenia, and these are strongly related to functional outcome of the illness. With these symptoms, the patient cannot continue her university studies. Maybe the delusions and the hallucinations can be solved by the usage of antipsychotics, but with these symptoms, which you cannot really influence by recent antipsychotics, the patient cannot function as he functioned before. And affective symptoms, typically at the beginning of the illness, majority of the patient have some depressive episodes. There is a phenomenon which is called the post-psychotic depression, when after the acute phase, after the acute relapse, after the disappearance of the delusions and the hallucinations, the patient develops a so-called post-psychotic depression phase. And this is very problematic because most of the cases, this is the time when the patients are discharged from the hospital, and this represents a risk for suicide. In schizophrenia, classically, the suicide rate was 10%, that about every 10th schizophrenic patient killed himself. Newer meta-analysis, recent meta-analysis, a little bit lower this rate and says that about 5 to 6% is the committed suicide rate in schizophrenia, but it's still very high. In the DSM-5 system, these are the symptoms. 2 or more of the following, at least of these first 3 should be presented, and the duration of the illness should be more than 6 months with the prodrome and with the residual symptomatology. In the ICD-10, the International Classification of Diseases, the WHO system, at least one of the following symptoms are needed. I do not read it, you can see. Or at least 2 of the others is needed for the diagnosis. And in the ICD-10 system, 1 month's duration is enough for the diagnosis. So there are differences between the ICD-10 and the DSM-5 diagnostic criteria of schizophrenia. The subtypes of schizophrenia were first described by Kraepelin in the time when the illness was called dementia praecox. Later, Bleuler, in his textbook and in his book of schizophrenia, also integrated these subtypes. And what we have to know that these subtypes exist in the ICD-10, but these subtypes do not exist in the DSM-5. But we have to know this because in Europe we use the ICD-10, so the subtypes are still important for us. Paranoid type, the disorganized type, which is also called hebephrenia, typically starts in the adolescent period. The catatonic type, the undifferentiated type, and the residual type are important. The differential diagnosis, substance abuse, certain neurological illnesses, I would like to emphasize temporal lobe epilepsy, which sometimes can mimic schizophrenia symptomatology, general medical conditions, and some psychiatric differential diagnostic issues are also mentioned in this slide. A schizophreniform disorder means that the patient shows the typical picture of schizophrenia, but the duration of the illness is between 1 to 6 months. In the case of schizophrenia, as we had seen in the DSM-5, it's over 6 months. Delusional disorders, schizoaffective disorder, mood disorders, autism, OCD, personality disorders, all can, in some cases, represent a differential diagnostic challenge. This is the course of schizophrenia. There is a pre-morbid phase, and we know from recent research that there are some pre-morbid signs which exists before the onset of the illness. For example, the IQ of patients, intelligence, quotiency of children who later develop schizophrenia is a little bit lower than the average. These are not mental retardation level IQ deficiency, but very mild, about 92 or 93, 94 is the IQ, which is a little bit lower than the average 100. And also some affective and motor dysfunctions can be identified very early in the so-called pre-schizophrenia phase of the illness. There was a famous study which was published in American Journal of Psychiatry by Walker and Levin, the home movies study, which was the following. The videotape recordings of schizophrenia patients were collected, and these videotape recordings showed the patients at the time when the patient was at the age of 8 or 10. And there were birthday parties when the later schizophrenia patient with other children played and enjoyed the afternoon in a birthday party. And the research was that psychologists were instructed to find out who will be a schizophrenia patient much later, decades later, from the children who play with each other. And with a very great significance, the psychologists could identify the child who later developed schizophrenia in contrast to the others who not. And some mild motoric dysfunctions, motoric disturbances and affective disturbances were identified as a tool for the psychologists to identify among the children who will develop later schizophrenia. So we can say that schizophrenia exists as a result of abnormal brain functioning much earlier than the onset appears. There is a prodromal phase when brief attenuated positive symptoms and functional change, functional decline can be seen in the prodromal phase. Then comes the first psychotic episode and the psychotic phase, and later a stable phase appears with negative symptoms, cognitive symptoms, social functioning is disturbed. So this is the course of schizophrenia, which is very important to know. The long-term clinical outcome of patients is very much variable. The recovery rate is approximately 14%. The majority of patients display exacerbations and experience clinical deterioration. About 25 to 42% of patients show a relatively good prognosis, and 10 to 15% of patients remain chronically and severely psychotic. So this is a distribution of patients, and the early phase is very important. The illness in the early phase means the first 5 years. In the first 5 years, the illness is more active. Patients respond well to treatment, but many times sensitive to side effects, and there's a lack of adherence in this early stage of the illness, and poor insight is important. The treatment is integrated care. We have to reduce the symptoms experienced by patients. We have to reduce the risk of a next relapse. We have to preserve the patient's long-term functioning and improve quality of life. And the best treatment is the combination, the complex treatment of psychopharmacological and psychosocial techniques and treatment approaches. We see the first and the second generation antipsychotics here, which I have already mentioned during the first semester in the biological therapies lecture, so I don't go into the details. The components of the psychosocial treatment are first, a very good therapeutic alliance is important, a strong therapeutic alliance. Adherence, increasing therapies are important. Family and patient psychoeducation, cognitive behavior therapy. And in pharmacotherapy, we can use Peros medications, we can use oral administration of the drugs, and we can use long-acting injectables, which help to promote the lack of insight and the non-adherence of patients, because with one injection we can solve the treatment for 1 month. And there is one drug, paliperidone, which has not only a 1 monthly, but there is a 3 monthly version of paliperidone. So with 4 injections during 1 year, you can solve the treatment of schizophrenia nowadays. And with this, I would like to thank your attention and emphasize that schizophrenia is a very important illness, and please read your books and book chapters on this illness too.